do in next 5 minutes is, you are all very learned people who knows everything about chronic coronary syndrome. But then guideline committee had to give something new. Whenever I read this document, wherever I felt paused and thought, oh, is it like that? Those are the 5 points I'm going to give to you. I'm not going to be talking on any definitions or anything. First thing is about the name. That is what was asked me to be spoken. Is it the change of the terminology? When I was being trained, MBBS, MD, DM, we learned a terminology called chronic stable angina. Then in 2018, they said, don't call it as a chronic stable angina, call it as chronic coronary syndrome. Okay, 5 years, somehow we learned to use CCS, and it was easy because there was a ACS. Now they said, call it as chronic coronary disease, not a syndrome, CCD. And this is how the topic was named. Then when I looked at this is the page that was heading. We used to have guidelines which are endorsed both by the physicians and the surgeons and all the other associations. But this was the first time surgeons said, we don't agree with you. So this is from the cardiologists. Surgeons don't agree with what I'm going to talk. So the name is chronic coronary disease. We used to have a very clear definition, 6 months pain, etc., to define a chronic stable angina. But today, the chronic coronary syndrome is anything that is ischemic heart disease and that is not acute coronary syndrome. That's all. You might have had an MI 1 year back. You could have developed an ischemic LV dysfunction. Everything gets involved in this bracket. This slide I brought in because lots of you and my patients have asked me, you get a CT coronary angiogram done and you find a calcium on it. Is it a coronary artery disease or a coronary syndrome? Does it become a chronic coronary syndrome because these people never had an MI? No. Calcium is just like telling somebody that your lipids are abnormal. So this is one point from this I wanted to carry home. Then it's more difficult to treat chronic coronary syndrome. It's a multidisciplinary approach. Unless somebody comes with an MI, I put a stent in LAD, I'm certain that I have reduced his mortality. But the same is not true for the CCD. So you have this very beautiful tool that is there. I brought in here because any one of you want to use it. You just put in certain answers to the questions. You get recommendations as to what to do, what medicines this patient should be on, what you are going to advise. And then there is an ischemia decision-making tool. And all these people should be involved in treating these patients. Your dietitian, your nurse, pharmacist, everything. And determinants of the health has to be considered. It's not like pain gets relieved or something, you are better. Look at the determinants of health, which may be educational, healthcare related, because you can't keep on saying somebody living in a remote place come every 2 months and get an echo done. So how the social determinants help. Then for the first time, there's lots of importance that's given to the nutrition. It's more to remove the myths than to give an advice. Because today we all have patients coming up and saying, no, sir, my heart will get cured because I'm in a keto diet for last 15 days, kind of a thing. So these are the something, but again, it all comes to going more towards the vegetables and reducing the saturated and super refined foods and alcohol. So this slide, only single message. We are all very comfortable using lipid management in patients with acute coronary syndrome. We all give 40 milligrams of rosuvastatin. But when we see a chronic coronary syndrome, we don't focus on a similar way. These are the patients need a similar targets. Like if you have a 70 target for a diabetic coming to with the coronary artery disease, whether they have a chronic coronary syndrome or an acute coronary syndrome, the targets remain the same. Antiplatelets. Again, lots of us sort of tend to use clopidogrel, aspirin combinations and all. Unless a patient of chronic coronary syndrome had an acute coronary syndrome or a stent, it is always aspirin alone. if they get a stent or if they get acute coronary syndrome, the guidelines change to that particular subset. This is one slide. Beta blockers. We were always taught it's must to have a beta blocker, but this guidelines say unless the patient has an MI or an acute coronary syndrome or a heart failure or a LV dysfunction, beta blockers are not any better than all other classes of drugs that you could use. Colchicine, new drug, has been recommended but not very commonly used. The last point I would like to touch upon is the revascularization, because lots of patients get revascularization in chronic coronary disease, and we get lots of lay press and media talking against it. So when we looked at the older guidelines, like in 2012, they said if the patient has a triple SL disease or the left main disease, do a CABG, it will help. But now what we noticed, even in such patients, without LV dysfunction, CABGs may not be of a use. So only class 1 indication now remain as if the patient has the symptoms of despite of GDMT and all kind of lifestyle changes, then only you send them for revascularization, or if they are having a severe LV dysfunction. All other patients, it goes to class 2B. That means we are telling not to revascularize many of these patients. So that is where the surgeons walked out. Until the last moment they were there, but when we said these people don't get benefit, they walk out and they come up with their own rebuttal. So emphasis is on the team-based patient-centric care, considering social determinants of health and associated costs. Emphasis on the shared decision-making in risk assessment and treatment of SGLT inhibitors and GLP. Beta blockers not recommended to improve the outcome in the absence of MI or the LV dysfunction. Shorter duration of DAPT are safe and effective in the circumstances that need it. CABG is no longer a class 1 recommendation to improve the survival in patients with triple SL disease if their EF is more than 35%.
Wonderful,
Thank
sir.
you.
Thank you so much. Wonderful. He gave us 3 minutes extra, and it cannot be better than this. Dr. Gigi will tell us about whether he would like